What I want to try and do today, and what I was asked to do, is try and add in the fact that most of the time when we're seeing patients with Alzheimer's disease, we're also seeing people with other diseases, heart failure, diabetes, and the like, and how we might think about the management of those problems in the context of this overarching disease of Alzheimer's. And so that's where we're going to start. I'm going to talk a little bit about end-of-life issues. We've got some additional presenters later in the program. We'll be going into a little bit more depth, but I'm going to sort of set the stage for that talk. And then we're going to, as we talked last week, talk a little bit about, the doctor visit, because my perspective is a lot of times people come in and they really haven't thought about what they want to go over and what they want to talk about. And if you're not organized, particularly in today's world, it goes by pretty quickly. So we'll talk a little bit about that too. And I'll talk about not only how you can get organized, but what you're seeing from the physician as he's trying to get through that 15, 20-minute, 10-minute visit, whatever it is, and what he's got to do. So maybe you have a little bit of better perspective of what is happening with your physician as well. But I thought we'd start with this picture. I don't know whether you recognize who these people are, but the gentleman on the left is Dr. Alzheimer himself. So I figure, if we're talking about a disease named after a man, we ought to put his picture up and recognize him. And the picture on the right is his patient. Okay, this is the patient that started this whole ball rolling back 110 years ago almost now. And remember that she was 54 when she came to Dr. Alzheimer's attention and 56 when she died. So, by today's standards, she's very, very young. But remember at the turn of the century also that life expectancy at the turn of the century was around 48 years of age. So, the average life expectancy at that time was by the way, I always bring this up whenever I talk about it, and anybody know where 65 for Social Security comes from? Oh, think of a good politician, come on. Okay, and usually somebody says Roosevelt, okay, because he was there when they passed but it wasn't Roosevelt. It was actually Bismarck. Okay, Bismarck in the 1880s told the German population that he would give them Social Security if they lived to be 65. But what did I just tell you? Life expectancy was only 48. A politician who's giving away something they'll never have to deliver on. We have a few of those in Louisiana. So what we're going to do is talk a little bit about chronic disease management in the light of these other medical problems that may come into play. And I've just named a number of diseases that we see routinely and chronically in patients with Alzheimer's disease. So what do we do? Do we do anything differently? Well, one thing about that we do differently is type 2 diabetes. Very common, and we all know that all the guidelines that you've seen, if you're diabetic, your glycosylated hemoglobin, the goal is to get it to 7 or below. If you're type 2, hopefully below, because we're worried about the complications that will develop 10, 20 years down the road if we don't. And the complications that we can prevent with tight control are eye disease, kidney disease, and neuropathies. But what happens when you get Alzheimer's disease? Sometimes patients forget to eat, okay, or they don't eat the right things, okay? And so recently, the American Diabetic Association and the American Geriatric Society have gotten together and said, maybe it's not a good idea, because hypoglycemia is also bad for patients and their brains, okay? And so now for patients with Alzheimer's disease or any patients in their in their 80s and 90s, we're probably 20 years down the road, we don't need to worry as much about complications because most of us are not going to live to 110 or 120 or even 100. They've said, glycosylated hemoglobin of 8 should be the target, not 7. So we can liberalize those blood sugars a little bit. Coronary artery disease, a common disease that we see in this group of people. Many patients are on beta blockers. Beta blockers lower the heart rate, but so do all of the cholinesterase inhibitors that we talked about last week. Remember the donepezils, the Aricept, Exelon, and galantamine. They also lower the heart rate. So we have to be careful about the combination of those drugs in passing. Chronic obstructive lung disease. Anybody here ever try to use a multi-dose inhaler? You know, you got to coordinate your fingers. Well, maybe that isn't a very good way to give the aerosolized drugs to patients with Alzheimer's disease. And we need to think about using discus methodologies like we have with Advair or Spiriva, or even using a nebulizer and using the peace pipe or the mask to deliver those drugs. Chronic renal disease often leads to the fact that we have to alter the doses of drugs for patients with Alzheimer's disease because of their kidney disease and the fact that all of us as we age lose renal function. Most of my patients' creatinine clearance is around 50 to 60, but we have to modify the dose of the drugs that we use for these diseases because of that, because they don't get excreted very appropriately. Osteoporosis drugs we have to be careful of because they're contraindicated for patients with chronic kidney disease. Hypertension, we want to make sure that we control blood pressure, but not too much, because we also see a lot of orthostatic hypotension in these elderly people on multiple drugs. And degenerative joint disease, that's just arthritis, okay? And we have to be careful about the use of any of these drugs with degenerative joint disease because we don't want their pressures to bottom out and put them at risk for falls because of their arthritis. Geriatric syndromes, falls, delirium, malnutrition, sensory deficits, incontinence, depression, anxiety, sleep problems, and polypharmacy. These are all things that my patients with Alzheimer's disease complain of and have problems with. And obviously a fall in a patient with Alzheimer's disease can be devastating. Oftentimes leads to hospitalization, hip fractures, and delirium. And what is delirium? Delirium is that condition where people are getting along at home just fine, but you put them in the hospital, and about 2 days into the hospital stay, they're up all night, they're picking at the sheets. The doctor comes in the morning and they're laying in bed just fine. That always happened to me when I was the intern. I'd be making rounds with the attendings in the morning, and I'd say, well, Mrs. Jones just had a horrible night. She was up and down, she didn't sleep a wink, and I'm preparing the attending for what he's going to see when he walks in the morning. Okay, Mrs. Jones is sound asleep when they're walking in. He says, what was the matter? She looks great, no problems. But, and delirium is something that is not dementia, okay? Delirium is something that's acute onset, okay? And often has changing levels of consciousness, so people will wax and wane. 1 minute they'll be agitated and irritable. As I said, the next minute they'll be very sleepy. One form of delirium that we need to worry about is the form that's hypomanic, where people are they're just there. They're not doing anything. They're not responding at all. It's often missed, okay, in our situation. Because of our malnutrition is something we see in our Alzheimer's patients, because particularly if they're living alone, what happens? They forget to eat. And they forget to eat because they're not hungry, they're not doing much, they're just sitting around, and they're not hungry, and they have to prepare the meal, and it's too much of a chore to prepare the meal. So as caregivers, one of the things you need to always look at is how much is the person you're caring for, perhaps not long distance, but not in immediate proximity, are they really eating? It's oftentimes I'll have daughters come in and say, yeah, we prepare frozen food for mom for her to eat and put it, but I said, well, does she do it? Well, they do stack up in the freezer. Okay, so be observant of that. Sensory deficits, we can talk forever about the effect of loss of hearing and loss of eyesight in patients with dementia and what that does to their sense of connectivity to the community that they're in. Depression and anxiety are probably part of Alzheimer's disease. You know, many patients with Alzheimer's disease have periods where they get very depressed, but it's probably part of the disease, not a new disease, not a secondary disease, but but it's also reversible with our current SSRI drugs if we dose adjust them. And one of the rules of geriatrics that I always talk about is start low, go slow. Okay, so we may not start with the same dose of the drug that we would give to a healthy 40 or 50-year-old person, but we start at a much lower dose and build up to an effective dose. And many times the effective dose will be that low dose. And polypharmacy, my favorite, okay? I had a lady today who came into the office. She had 13 pills with her when she came in, okay? And I started talking to her and I asked her, why do you take these pills? What do you take them for? She only knew what she took one of them for. Okay, and then I took a look at the pills and the pill bottles and looked at the dates that they were filled and said, you got this filled 2 months ago and you got 90 pills and looks like there's about 75 of them still here. Basically she left with 5 pills. Okay, we just took her off a bunch of stuff. She wasn't taking it anyway. Okay, and then we said, okay, let's go ahead and get somebody to set out your pill reminder system, fill those little bins, and come in and do that weekly and let me know how many doses were missed, and maybe we can take care of further drugs that we find out you're really not taking them. Or we find out that you do need one of the drugs that we stopped today, simply because now something has gone wrong. So we'll look at that in the future. So one of the things that we've all been subjected to recently is clinical practice guidelines and how do they apply to the patient with Alzheimer's disease. And many of the patients that we're seeing now, I'm talking about the classic Alzheimer's disease where patients are being developing their disease in 75 and 80 years of age. Well, guess what? All of the clinical guidelines that you'll see posted, you go on the web and find out what should I do for my diabetes or my hypertension. There weren't any 75 and 80-year-olds involved in any of the studies that led to the development of those guidelines. So oftentimes, as a geriatrician, we find ourselves sort of like a pilot in 1925. Remember what pilots said they did when they flew in 1925? If you don't, they said they flew by the seat of their pants because they were plowing new ground. Nobody knew how to fly or where the airports were and where the landing strips were and how to get down and up. And they didn't have all of the altimeters and other things. I hope there's no pilots in the room. I'm not one. But they didn't have all the instrumentation that they had today. So they had to learn on their own. And they flew by the seat of the pants. Well, a lot of us taking care of 80 and 90-year-olds are doing the same thing because, as we talked last week, many of the drugs that we do have available, we extrapolate their use to the elderly. We don't have any good studies that that tell us about that. One of the other things about clinical guidelines, they expect that we're prolonging life expectancy, but in this disease we know that we're going to have a truncated life expectancy, and do we really need to be as adherent to those guidelines when life expectancy is much shorter? We have to look at patients' functional status as to, does it, for someone who is declining in health, do we really want to impose these same restrictions and all of these medicines on them when they're not getting up and getting around the way active people were that led to the development of the guidelines, and look at the patient's quality of life, and then apply what makes common sense. And maybe you loosen the guidelines for hypertension, or you loosen the guidelines for diabetes, as I already went over, or you modify how you're going to do things. Because sometimes, maybe the burden of the treatment plan that you create, okay, becomes so burdensome that not even I can follow it. I always tell patients when I see them and they come in, I tell them I see the letters KISS emblazoned on their forehead. You know what that stands for? Keep it simple, stupid. And remember, that's telling me keep it simple. Okay? So we can't have a drug regimen that is too complicated to follow and have somebody at home dealing with moderate Alzheimer's disease, still able to get through the day okay, but a complicated regimen that most of us couldn't follow probably isn't going to get followed in that person anyway. So keep it simple, simplify things. We have to look at what patients' and families' preferences are and how much of a burden the symptoms are to the patient and address that. We have to look at the quality of the patient's life. I always talk to folks with this disease and their family members and talk about quality of life. That's what we're really trying to preserve often in this disease, not extending life indefinitely, particularly as patients remember less and less about their life, their family, and their loved ones. We have to look at the risks of the interventions that we're proposing. You know, are we putting people at bigger risk for the sake of a guideline? And then we also have to take into consideration, you know, sometimes we'll see a study that says that there's a 50% reduction in something because we do an intervention, okay? But if the incidence of the disease is 1% and we reduce it 50% to 0.5, is it really worth all the trouble? And is it worth risking these drug-drug interactions by intervening? Okay, because maybe we're offering very little additional benefit, absolute risk reduction, as opposed to just what the guideline says. Well, I talked about the complexity and non-adherence. I've already addressed that. We always have to worry about adverse reactions to drugs. And, you know, a lot of times when we talk about drugs and 10 drugs, 13 drugs, as I mentioned earlier, data suggests that anytime you have 5 or more drugs, you're going to have at least one drug-drug interaction. It may not even be recognized. It may not be recognized in the medical literature. It may not be recognized by the patient. It may not be recognized by the doctor. It may be called aging. Okay? So, you know, I frequently have talked about my partner's mother-in-law who came to town on 13 different drugs and was very hard to control and manage and make things happen for her. And my partner, when she came to town, she was no longer under the care of 5 or 6 physicians over in Texas. And my partner said, well, let's just stop everything. Her mother-in-law is doing just fine. Okay? Actually, her mother-in-law is doing better now that she's off of a lot of medicines. So, you know, we in America love our medicines. Okay? But sometimes we need fewer of them, particularly as we get older, and I'll talk a little bit about that further. And then we also have to look at, you know, how much stress is all this doing to the caregivers? You know, and do we have to be, you know, I always tell people when I'm seeing a patient with Alzheimer's disease, every time they walk in, there's somebody that comes with them. Okay? So I really have 2 patients. Okay? The caregiver may not be my official patient. I may not be seeing them. They may be managed by another physician here in town. But I really have to look out for their well-being as well. Because if they get sick, okay, who's going to take care of my patient? Issues with polypharmacy. We often see inappropriate prescribing. And I'll give you an example of that in a minute. We talked a little bit about delirium earlier and what it is, but oftentimes given drugs will induce delirium, okay? A lot of the delirium that I see is in post-op hips, and that may be to some of those anesthetic agents that we give. And, you know, we can't get around it, but at least we recognize what it is and treat it appropriately. Anticholinergic burden, we'll talk a little bit about the anticholinergic drugs and what they may do to patients with dementia and give you some sites as to what they are. Antipsychotic use. A lot of times for behavioral issues with this disease, we use the antipsychotics, the Haldols, the Seroquels, the risperidones of our world. They've never been proven to be effective. They do have side effects that we have to be aware of, and if we're going to use them, we don't use them in the doses that we use in patients who are truly psychotic or patients who have schizophrenia, the disease for which these drugs were designed and tested on, but we use very, very low doses for limited periods of time. And very honestly, as I mentioned earlier, there's a limited evidence base. for all of this. It's still flying by the seat of our pants, so we have to do it carefully. Start low, go slow. And then the second rule of prescribing for elderly patients is if it doesn't work, stop it. Okay? You know, don't just add another. If you try something and it doesn't work, don't add another drug. Make sure you stop the one that was already done. So I'm going to just go over some of the things that I see with regard to managing these other illnesses in Alzheimer's disease, and some of the things that we can look at as physicians, and you can bring up to physicians as you know, can we simplify things? A lot of times I'll see people come in with their hypertension drugs and they're taking 3 hypertension drugs, but they're all at very low doses. Maybe it's better that we try one drug and push it to a little bit higher dose to see if we can't get the desired effect and try and limit the number of drugs. One of my pet peeves is today in hospitals, everybody's on a PPI. If you don't know what PPI is, you really do. They're Nexium, they're Protonics, they're Prilosec, okay? Those drugs that we all take or people take for heartburn and take for ulcers, okay? All of the data on those drugs was done in studies that were run for 3 months. We talked about that last week a little bit, okay? And in 3 months, 95% of all ulcers heal. So if you have an ulcer and you're put on a PPI, do you really need to take it for the rest of your life? Okay? And today in our hospitals, we're seeing people being put on these drugs because hospitalizations are stressful. And we know, and there's an article that I saw today that again points out that even outside of the infection that we now know is associated with ulcers, Helicobacter, we also know that stress causes ulcers. So people, when they're hospitalized, get put on these PPIs. But these are not benign drugs. The longer we use them, we've learned that there are side effects to their use. Development of osteoporosis. There's an increased risk of pneumonia and TB in patients who take these drugs long term, because now we've turned off all the acid in our stomach. And so the acid in our stomach is no longer there to kill the bacteria that are in our stomach and in our upper GI tract. And then the other thing that happens with these drugs, if you're on them for a long time, if you try to stop them, you get a rebound phenomenon. So you stop the drug after somebody's been on it for 2 or 3 years, and what happens? They get really bad heartburn. Okay? They get really bad heartburn. So then you have to go back and start all over and start and taper gradually. So if somebody is in the hospital, if you have a loved one who was never on one of these drugs, they're put in the hospital for a pneumonia or a urinary tract infection or some other reason, and they come home with a PPI, question whether they can't stop these drugs. Okay? Because they probably don't need them. They weren't on them before. They never had any problems with ulcers or heartburn. You don't need to be spending $100 a month. That's what they cost. Okay? You don't need to spend $100 a month to continue their use. The gotta-go drugs. You know, the incontinence drugs that we see. And you know, I think that the ads are pretty good. You know? But oftentimes we have our elderly patients with dementia who have incontinence. But it's not the incontinence of urgency. It's just the incontinence of age. It may be incontinence related to immobility. They can't get to the bathroom on time. They may not recognize the symptoms that, hey, I gotta go. They may lose that recognition that they've gotta go. And they also are, as we've already mentioned frequently, they're older and they have pelvic floor instability. The gotta-go drugs don't work there. Okay? So if you're gonna try these drugs, I'm not saying never try them, because sometimes they do make a little bit of difference. But if you're going to do it, I tell people what you need to do before you start is keep a log for a week or 2 weeks. Find out how often you're dealing with incontinence. Then start the drug and continue the log. And find out whether you've changed anything or not. Because if it hasn't changed, then it's not working. Okay? Because these drugs also have side effects. Dry mouth, dental issues, constipation, and confusion. And a lot of them have the anticholinergic effects. We need to be careful about, do we really need to continue statins forever and ever and ever? Cardiologists think so. But you know, if you've been on a statin for 10 years and you have a life expectancy of 5, you've probably delayed your coronary disease by at least 10 years. Okay, continuation of the drug may not be, and you know, you're probably not eating the same way you did. Your intake is different, and your cholesterol, oftentimes with these diseases, we see cholesterol levels go down. So they may not need to continue the statins, and they have side effects, muscle weakness leading to falls. We see a lot of use of Zetia. Zetia has never been proven to lower the risk for heart disease, okay? It's been proven to lower your cholesterol, but we have to be careful, okay? We don't take cholesterol-lowering drugs to lower cholesterol. We take cholesterol-lowering drugs to lower our risk for heart disease. That's the reason we're taking the drug. And we've proven with the statins that we can do that. Okay? But Zeti's just been proven that it can lower that surrogate marker, that blood test. So be careful. And ask the question, and the new guidelines really bring that into question, whether we really need to get everybody to go. Maybe the statins do more for coronary artery disease than just lower cholesterol. Antihypertensives, we worry about weight loss, and the role of weight loss may be that if people are losing weight as they age, now they've lost one of the reasons that they're hypertensive. And you can lower the risk, lower their blood pressure medicines, and then also be careful how their blood pressure is drawn or measured. If you walk into a doctor's office, they put you on a scale, you find out you're 5 pounds heavier than you thought you were, and you've had an automobile accident or just a near-miss automobile accident on the way into the office. What do you expect your blood pressure is going to be? You know, so make sure the doctor takes the patient's blood pressure after they've been there for 5 or 10 minutes, particularly if the Alzheimer's patient is agitated. Be careful of non-steroidal anti-inflammatories, another one of my pet peeves. You know, these are the arthritis drugs, the Aleve, the Mobix, the Relafins, the Celebrexes of the world. These are the #1 reason why people come into our emergency room with GI bleeding. They can also cause kidney impairment and hypertension. Actually, causing hypertension by these drugs is a classic geriatric board question. And so these are drugs that have adverse effects, and Tylenol will oftentimes be just as effective for pain. But you got to use Tylenol the right way. Aleve, in their commercial on TV today, I think emphasizes the fact that Tylenol is a short-acting drug. And so what happens to the UPS man who's delivering his things? He's got to stop at noon to take some more Tylenol. He's got to stop at 4 o'clock to take some more Tylenol. So if you're going to use Tylenol for arthritis pain, use Tylenol arthritis because it's a long-acting drug. What we've done is modified the pharmacology. The drug gets absorbed more slowly from the GI tract, and therefore the drug has longer action. And so you only have to take it twice or maybe 3 times a day. So you get the Aleve effect, because you only have to take Aleve twice a day. Okay, you get the Aleve effect by using Tylenol arthritis, not extra strength, but arthritis. Benzodiazepines. There have been a couple articles recently on benzodiazepines. You know, these are any drug that ends in lorazepam, alprazolam, anything that ends in am, Klonopin. These are drugs that we often use for anxiety. We often get called to put people on them for grief. They're also often used for insomnia. Incidence is high, lots of side effects that go along with these drugs. I mentioned mobility. Unfortunately for many of our Alzheimer's patients, motor vehicle accidents aren't an issue, but falls and fractures are. So really try and not use these drugs, get people off of these drugs. There's also a recent article in Lancet, a famous British medical journal, that has made at least some correlation between the use of these drugs and the development of Alzheimer's disease. So maybe I'm not saying that there's a tight relationship there, but they certainly saw that patients with Alzheimer's disease early in their life, people had used more of these drugs. So just a word for the wise. What I've done here, this is a program by the American Board of Internal Medicine. They've asked all of the specialties to come up with things that they would recommend people not do or choose wisely about doing. And this is for geriatrics. It's not against feeding tubes for Alzheimer's disease. Always look at patients and say, if I were in that position, would I want to be kept alive with a feeding tube? And we see patients and families who still today want that tube done, but we definitely avoid or try and avoid their use and promote what in the literature is called a natural death. We've already talked a little bit about antipsychotics. We've talked about diabetes, the benzodiazepines, antibiotics for bacteriuria without lower urinary tract symptoms. Very, very common. With Alzheimer's disease, it's probably one of the biggest dilemmas that we face. Patients can't give a really good, reliable history. Is their confusion really, or their worsening of their confusion really due to the bacteria that we see in their urine, or is it due to the fact that they're mildly dehydrated because they're elderly, their sense of thirst is declined, and they're just not drinking enough? Of course, if you put them on antibiotics, whether they're IV in the hospital or whether they're PO at the nursing home or at home, everybody is told drink plenty of fluid with the antibiotics. So guess what? We give them the antibiotic, we give them fluid, they get better. It was obviously the antibiotic, okay? But the Infectious Disease Society has really cautioned us about the overuse of antibiotics in this condition, and we're hearing about that as we hear about more and more multiple drug-resistant organisms and what that may do to us. If we continue at the rate we're going, very quickly we may be back to the 1920s and 30s before the advent of penicillin. And we'll see bugs reemerge that we can't kill with our current antibiotics. And because of financial incentives, there's not a lot of research being done on new antibiotics, because what would you rather develop as a drug maker? A drug for Alzheimer's disease that people will take for 5 or 10 or 15 years, or an antibiotic that they'll take for 7 days? Where are you going to make your money? It ain't going to be in antibiotics. Evaluate, as we talked last week, about cholinesterases and whether they need to be continued. Think about screening for breast, colon, and prostate cancer in those people who have shortened life expectancies. We probably don't need to continue doing all those procedures on people, and particularly patients with Alzheimer's disease. Imagine as a woman, I've never had one, but imagine as a woman, from what my patients and my wife tell me, if suddenly somebody's squishing your breast as they do with that mammogram, and you don't really understand what they're doing or why they're doing it, what does that do? What does that do to them? We don't like appetite stimulants. We try and avoid polypharmacy, and certainly we avoid restraints. We don't like people being tied down. And just think about what you would feel like if you were tied down. So now we're going to switch gears. My second topic was end-of-life issues, and I'm just going to talk a little bit about, increasingly, and with the ACA, everybody is going to be asked about their preferences toward the end of life. But particularly, as we said, this is the 6th leading cause of death, Alzheimer's disease, in the country today. It's a costly disease. And as we've discussed a little bit earlier, what would our family members want? What would we want if we got in that position that they are in today? And how do we direct our physicians and our EMS personnel to deliver that care? So one of the things you should know, when EMS is called and arrives on the scene, their charge is to do everything, okay? And they will do everything. They'll put tubes in the field. They'll do CPR in the field. They will transport people, and they will do everything to preserve life until they can transport that patient to a healthcare facility where they can pass the patient off to physicians. So if we don't want all those things done, We have to have a mechanism by which we can communicate those wishes to our attending physicians, whether they be our primary care doctors or whether they be the emergency room personnel. So how do we do that? Well, for a long time in this state and others, we've had the living will. As a practicing physician, the living will is a good conversation starter, but as a legal document, it's pretty worthless. Okay? Because it requires that two physicians have to agree that you have a terminal illness, and that's not always easy to do. And there may not be time for two physicians to get involved in some cases. And patients, oftentimes, when we need to know what's going on, the patients aren't capable of even letting us know there's a living will around. So I think if you need a legal document, the legal document you need is a healthcare power of attorney. Okay? And with a healthcare power of attorney, what you do is you draw up a legal document that appoints somebody to act on your behalf, and hopefully you talk to them about how you want them to act, and they then carry out your wishes when you can't be queried to know what your wishes are. And hopefully that's somebody who's close to you so that they will be around when and if that time comes where they need to act on your behalf. Another powerful document that we've just passed in this state is the Louisiana POST document. And POST stands for Physician Order Set at Terminal Illness, something like that. I can't remember what it is right now. But basically, what that is that it's a statement of what you would want done. Would you want CPR? Would you want to be put on a breathing machine and maintained on a breathing machine? Would you want IV antibiotics or IV fluids? Would you want a PEG tube? Would you want dialysis? Okay? And you create this set of what you would want if you have a terminal illness, and you have your physician sign it. Okay? You then keep it at home, and so that if EMS does get called, they have now a physician's order set that tells them what to do. And it can stop the intubation in the field if it's inappropriate or is undesired. Because we do have one thing that we have to do is we have to respect patients' wishes. And then lastly, a few words about hospice care. Hospice has certainly increased in popularity in this country in my professional lifetime. It's used far more frequently today in diseases other than cancer, where it originally got its foothold here, particularly in the States, not so much in England. But in Alzheimer's disease, it becomes a sticky wicket because it's very hard to predict. It's much harder to predict in Alzheimer's disease longevity than it is in end-stage heart failure or cancer, the two other, or end-stage lung disease. Usually in those diseases, we can predict when patients are deteriorating and when they have a limited time left. We're not always good at the 6 months. That's a creation of the legislature, and we know how good they are. Hospice care can add benefits, and there is now an inpatient hospice, but it rarely applies for Alzheimer's disease, only because for qualification for inpatient hospice, you have to have active management of pain. And most of our patients with Alzheimer's disease really don't have that. Sometimes they will get where they just become totally unresponsive, but they won't die immediately, and they're not eating, and there the inpatient unit can be helpful for families who for emotional or other reasons, just don't want the patient to be at home, or they feel incapable of caring for them at home appropriately and feel as though they need professional help. So my colleague Miranda is going to be talking a little bit more about these issues when she's up here on St. Patrick's Day night, of all times. One thing, do not resuscitate orders, I think, are oftentimes misunderstood. And so I want to try and clear up some things about do not resuscitate orders. It doesn't mean we stop any treatments. Okay, sometimes the perception out there is do not resuscitate means, well, we don't do anything anymore. No, it doesn't mean that at all. It means we continue doing everything we're doing. We continue to try and reverse the disease at hand, whether it be Alzheimer's disease and lack of nutrition, or whether it be heart disease and heart failure. We try and we do everything we can to reverse the process, but if the process is going to continue and not be responsive, we don't put people on breathing machines and we don't pump on their chest. And in this disease, I think it is extremely important to understand that that is a very aggressive and assaultive process. For many of the patients with end-stage Alzheimer's disease who are in their 80s and 90s, we're going to break ribs. You can't do chest compression well without breaking ribs. And remember that the 80 and 90-year-old, particularly the 80 or 90-year-old female, those ribs are pretty brittle. So we really need to understand that do not resuscitate, or CPR is a very, very aggressive and very, at times, painful situation. The other thing is, it's not very successful. Okay, so Harvard, this was a study that was done in the 1990s. Harvard at the Mass General did a study, and they looked at, Mass General being one of our premier teaching hospitals in the country, where the best and the brightest of the Northeast go to train. And those premier trainees are in the hospital 24 hours a day, 7 days a week. So they're there and they're Johnny on the spot when something happens. And they've got the best technology around them. They looked at success rate of CPR at the best hospital, one of the best hospitals in the country, with the best people around, okay? And what they looked at was success rate in the hospital of CPR in patients over the age of 65. Success rate. Success was defined as discharge from hospital alive. Okay, it wasn't success of CPR. It wasn't success of, we resuscitated the heart, we put them on a ventilator, and they got to the intensive care unit. It was success as discharge from hospital alive. Anybody want to take a guess? This was a year study. It was reported in Annals of Internal Medicine in the mid-90s. Success rate was 3%. So we're not, it's not like taking an appendix out, okay? So we have to be careful about CPR in the very old. We talked about this as part of the La Poste document, talking about other issues, intubation, hydration, nutrition, end-stage renal disease, antibiotics. And in my nursing home practice, we often talk about, do we really want to take the patient back to the hospital? Because as patients decline, hospitalization can be very, very stressful to them. Doctor's visits, okay? One of the things I tell people all the time, and I really do mean it, bring all the medications. I don't know why we have a 1 there by that. It should be I missed that on my proofreading. But bring all the medications. Well, no, maybe the 1 is right there. It's number 1. Bring all the medications. And I mean all the medications, prescription drugs, over-the-counters, eye drops. We talked about the anticholinergics. Okay, what's the most common anticholinergic that I see used? And anticholinergics, remember, block the effect of acetylcholine, the thing that we're trying to improve and to make more of in the brain when we use Aricept, Exelon, and galantamine.
Rolate. Rolate.
No. Most common anticholinergic that people take? Benadryl. Okay? Benadryl is highly anticholinergic. Okay? It's in everything. Okay? Advil PM, Tylenol PM. Guess what the PM is in all those drugs? Benadryl. What do moms give to their children when they want them to sleep? Benadryl. Okay? But Benadryl in the aging brain is not a good thing. Some of the other drugs that we still see used, one of the more common ones are the tricyclic antidepressants, which are still around. Amitriptyline or Elavil is highly anticholinergic and should be avoided in the elderly. There are other drugs but those are the two that I really Muscle relaxers can be anticholinergic, as can some of those got-to-go bladder drugs, particularly oxybutynin. And by the way, people are forced into oxybutynin because our Part D pharmacy benefit managers like it because it's generic and cheap, and the other drugs are not generic and more expensive. So everybody's got to get oxybutynin before they can get something else today. So over-the-counter agents, eye drops. I had a patient who took Timolol for their glaucoma. She kept coming, she'd come in. She'd never come in at 8 o'clock in the morning or 2 in the afternoon. It would always be 2 a.m. They'd fly her in from neurons. We couldn't figure out why she was coming in acute congestive heart failure until somebody brought in her eye drops. And she was taking Timolol. And eye drops can have systemic effects, and she was just very sensitive to them. Health foods. I had one patient who literally came to my office with a Tupperware bin. You know, not one of these. Okay, it was filled with health foods and rose hips. I asked her why she took rose hips. She told me it had become a religion for her. So and she was falling and doing a lot of other things, and we were trying to remove step by step these health foods. I didn't get very far with her, I have to tell you. My last visit with her, she told me that I was the devil incarnate, and that she was not going to take my advice, and she died about 6 months later. I suspect still taking all of her health foods. When you go to the doctor, maybe not you, but I see a lot of people who come to the doctor. They don't have anything. They don't have anything until they start talking. And the doctor starts asking questions, and then all sorts of things start coming out. Okay, and it's in random order, or it's brought up. You know, the doctor's done everything he wants to do, and he's getting ready to leave, and said, "Oh, doc, I forgot to tell you about this and that and the other thing, and it's something that's really important." Well, come in and tell us that, because unfortunately, in today's world, we only have 15-minute appointments. Maybe in my office it's 20, but in most offices it's 15. Sometimes it's even 10. So, you know, get organized. If you have something you want to talk about, make sure you put it at the top of the agenda. Okay? I'm perfectly happy if people have a list. Okay? Because if you bring in a list and there's 10 problems in it, and the first problems take the 20 minutes, okay, hopefully the list is prioritized, and if it doesn't look like it is, I'll ask you, okay, to prioritize it, because, you know, I've also got an obligation to all the other patients that are scheduled behind you. Now, there are times, and Trent will agree, there are times when people come in and they've had a 20-minute appointment, and they've got a 40-minute problem. Well, that's okay, you know, we'll take care of it, but if you've got a problem, you know, if you've got 10 problems, and we take care of the top 5, you know, maybe we just say, we're going to have to wait and go over the last 5 next time. But I already know what the next 5 are. Okay? And it makes for a much better experience for the patients, I think. And don't be afraid to ask questions. There's lots of community resources out there. If your doctor doesn't know about them, ask him. You know, or if you don't know where they are, ask about community resources. If he can't find out, oftentimes, you know, one of the nice things about this community, if we don't know it right away, we can always find out where it is. So I've talked a little bit about the doctor's perspective. It really is, we've got 15 minutes to get in and out. And increasingly, we are also being told we have to do a lot of additional things that we never used to do in the past. Okay? We never used to have to code. So now we've got 13,000 diagnosis codes. So when you come in, I've got to make a choice between 13,000 diagnosis codes. The bad news is that's going to 70,000 diagnosis codes on the 15th of October of this year, unless Congress acts. Well, Congress can't act. So you know, there are lots of things that we're being asked to do. We've got those guidelines, and every insurer wants to know how we're doing on the guidelines. And what they're going to do to us is that they're making us collect all the data for the guidelines, and then what they're going to do is put it on the web and tell you how good we did on the guidelines, so you can choose the most cost-efficient, best doctor. But if the guidelines don't really fit your position, well, who knows what's going to happen with that. But the other thing about the guidelines is, and the reasons why doctors have to do them, is because if we don't do them this year, next year we're going to get a 6% pay cut. So there are a lot of factors that your doctors are, and then we have to deal with EMRs. I didn't even mention any EMRs. Those most efficient things, you know, that we're going to, that the people up in Washington who drink the Kool-Aid told you that all physicians are going to be interconnected, and you know, your primary care doctor will be able to talk with your cardiologist, see your cardiologist notes, and you'll be able to see your urology notes, and you'll be able to see your orthopedic notes. Well, guess what? It don't work that way. Okay, so give us a break a little bit. Okay, but hold it. You know, make sure you ask the questions. You know, people say one phrase I never like is somebody will say, "I got a dumb question." There are no dumb questions. The only dumb questions are the questions that weren't asked. Okay, so I think I've talked for my allotted time. Maybe ran 5 minutes over, and I think we'll go ahead and